Welcome back. Module 1 here, upper cervical anatomy and biomechanics. Let's jump right in. But before we start, I do have one question for you. Here we go. What do you think is the most important part of your body? Now think about that. I'll give you a few seconds. Is it your heart? Is it your spinal cord? Perhaps your brain? Or is each part equally as important? Now, I'm here to tell you that the most important part of your body is indeed your brain. And this isn't just my opinion, it's a scientific fact. Now, here's why. Your brain is the only organ in your body that is completely surrounded and protected by bone, of course, with a small hole at the bottom for the spinal cord. But there's no other organ in your body that is prioritized more than your brain. Sure, your heart is important, but there's only a few ribs to protect it. Even your spinal cord is important. However, your spine, it's not a long, hollow tube of bone, right? Because your spine is it's separated into individual bones, which we call vertebrae. Now, of course, it must be this way so that way you can bend and move around. But that's why we say, a little behind here, that's why we would say the second most important part of the body is going to be your spinal cord, because it is the second most protected organ in your body. Now, sure, I would agree that you need each and every organ in your body for longevity and good health, but what I want to be clear on is that anatomically, the brain and the spinal cord are the two most important parts based on how it prioritizes. Okay, hear me out. Intellectually speaking, think about this for a second. Where's my female therapist at? Raise your hands. Here's what I want you to do. Picture your very first date. You and your partner go out to dinner, you have a nice meal, you go to the movies after, and then after that, you go to the park, walk around, let's say, you're talking, it's very, very romantic. Now it's getting late, so you decide to drive home. Your partner walks you up to your door, and this is your first date, but you really like each other. So they lean in for a kiss. Now again, this is the first date, so they're playing it safe here. Nothing on the lips. So you close your eyes, expecting a kiss right here on the cheek. But as they go in, they lean in, they actually trip and stumble over your foot. And instead of kissing you here, they kiss you back here, right underneath your earlobe. Whoa. Now, is that the same question? No, is that the same question? Is that the same message? What do you think? Same message, right? It's only, what, 3 inches apart? Only 3 inches apart. Why is it a different message? Because it is. I hear you. It's a completely different message. But why? Think about that. Why is it a different message if you really think about that? It's because you subconsciously know that this is public and this is private. Now, this area back here is far more important to you than this area up here in your cheek, right? Now, here is the point. I want you to picture how you would feel inside if a total stranger or even a big lover of 30 years, we'll say, kisses you back underneath the earlobe. Now, I bet we can all agree that regardless of who it is, whether it was a stranger or someone that you love, some sort of full body physiologic reaction will occur. Now, it's simple, just how, just a simple kiss can have an effect there. Just imagine what a major injury is going to do to the upper neck and how that's going to influence the rest of the body. So I just want to plant that seed in your brain. Ponder that thought. It's just something to think about. Of course, we will cover more on this in the neurology module, But for now, I just want you to understand the importance of the upper neck, both anatomically and intuitively. Okay, moving on to cervical anatomy. Now, starting at the very top, we have the occipital bone. Now, with the occipital bone, you have two convex condyles here in pink. These are going to be just outside the foramen magnum that articulate with the atlas, or C1, right here in green. Now, notice with the atlas, there's going to be two concave surfaces right on the top, which are meant for the occipital condyles to sit in. Now, notice the atlas, it's much larger and much wider compared to any other cervical vertebrae. It's shaped like a ring. There's no spinous process or body. Now with C2, right down here, it is also different than any other cervical bone, but it does have a body and a spinous process there. Now the difference here is that it has a long bony process on the top, right here, which is called the dens. Now this is going to allow for 50% of rotational head movement, right? Because if you didn't have that, you wouldn't be able to turn your head very far, all right? Now lastly, we have the rest of the neck bones. You can see over here and over here, C3 to C7. C3 to C7 are very similar to each other. They all have the same anatomical makeup. They're very stable. And we'll kind of get into why they're more stable with biomechanics module. Okay, let's move on to soft tissue here. Spinal discs. Now, first and foremost, notice that there is no spinal disc between C1, C2 over here. There's no disc there. Now, why do you think that is? It's because of mobility. If C1, C2 did have a disc, you would not be able to turn your head past 10 degrees of mobility. Because if C1, C2 did have a disc, right, you wouldn't be able to turn. Now, this is why with C3 all the way to C7, they're each going to have a compression absorbing disc in between them, which is going to add to their stability. Yet at the same time, it's going to decrease their mobility. Now with the disc, there's going to be a couple different parts. First, we have the outer portion of the disc, which is called the annulus. Now this is a tough circular exterior made of collagen fibers. Again, it's going to add to the rotational stability of the spine. If you associate one thing with the spinal disc, associate that with stability. Okay, now, second part of the disc, we have the inner part. It's going to be called the nucleus. Now, in order for a disc to function properly and act as a shock absorber like it should, it needs to be well hydrated. Now, a normal disc is going to have 80% water. So as the disc wears out and degenerates, it's going to lose its water content and kind of shrink down. Definitely don't want that. Okay, moving on to the nerves of the upper cervical spine. We're going to start with the suboccipital, just exiting above C1. Now, the significance of the suboccipital nerve is that it is only responsible for motor function only. You can tell how it's just such a priority. There's no sensory, so it's strictly focused on motor, telling other muscles to relax and contract. Now, there are 10 muscles specifically that are controlled by this nerve. We've got the geniohyoid, rectus capitis anterior. We've got longus capitis, rectus capitis lateralis. We've got splenius cervicis, rectus capitis posterior major, levator scapula, thyrohyoid, omohyoid, and sternohyoid. Now, although that sounded like a laundry list, I will break down some of these muscles into more detail soon. Focus on some of the more important ones. But let's move on to C2. We've got the greater occipital nerve. Of course, the significance with this one is that it can be easily entrapped by the obliquus capitis inferior muscle, which is going to cause cervicogenic headaches. So if you have patients with cervicogenic headaches, look to see what's going on with the obliquus capitis inferior muscles, both right and left. We'll touch more on that muscle specifically in a couple minutes here. Now, here we go. We've got lesser occipital, also going to be coming out of C2. This one's responsible for motor and sensory. It's going to control the scalp, face, and the side of the neck. Now, personally, I see quite a few patients with trigeminal neuralgia and jaw pain, and they respond really, really good when we can remove the pressure from this nerve specifically. Okay, moving on to the transverse cervical nerve. This is going to branch off both C2 and C3. Also going to be responsible for motor and sensory to the scalp, face, and the side of the neck, and even in the anterior neck too, because it's going to control the platysma muscle, which is going to kind of cover up just the anterior aspect there. Now moving on, great auricular. Again, branching off of C2 and C3. This one's responsible for sensory of the skin underneath the parotid gland, mastoid process, and kind of that outer ear. Lastly, we have the ansa cervicalis branching off of all three, C1, C2, and C3. And this one's going to be controlling motor only to the infrahyoid muscles, similar to C1. Now the infrahyoid muscles are going to be the sternothyroid, sternohyoid, and then omohyoid. Moving on to vasculature. Starting here with the vertebral artery, you see it side by side here. We've got the anterior view and then the lateral view. Now notice here, we've got two on each side. Both of them are going to be going up through the transverse foramen of the cervical neck. You can see here each hole going all the way up. Now notice here, as they go up, you can see that the pathway is very aggressive up here at the top. Just look at it on this view over here. Look how massively lateral it has to go just to get through C1. And then once it does make it through C1, look at how it has to go massively posterior just to get up to the brain. Now, imagine what this path would look like if the atlas was stuck in some sort of rotational misalignment. It's just incredible, and I see this all the time. But ultimately, the purpose of the vertebral arteries is to bring blood up to the brain. We're going to start bringing it to the upper part of the spinal cord, and then the brain stem, and then that posterior aspect of the brain. Alrighty, moving on to veins. Moving on to veins. Here we go. Now, okay, of course, what must come up must come back down. And although there is a lot more blood exchange that occurs inside the brain, we will just cover the vertebral veins and then the internal jugular vein, because these are the two veins that have the strongest relationship with the cervical spine. Now, we've got the vertebral veins on the left side here in green. They're going to be traveling in tandem with the vertebral arteries through the transverse foramen, of course, bringing blood from the brain back to the heart. Now, moving on to the internal jugular, right here, as you can see it, it's this big one coming down the side. We've got two that come down the sides right here, right here. Now, although the internal jugular does not travel within the cervical vertebra, it's going to travel immediately anterior to the transverse process of atlas. And I included this one just because with it being anterior to the transverse process, you can imagine, here again, if the atlas was rotationally misaligned on the anterior side, just imagine what that's going to do to that vein. It's going to compress it, and that's going to disturb the entire body's ability to drain blood normally. Now, I could dive way deeper into this topic and talk about Eagle syndrome, where you have an anterior atlas rotation into the internal jugular vein, which is going to be also compressed against the styloid process, which is kind of, think about it, the internal jugular is literally sandwiched between the atlas transverse process and the styloid process. There's tons of research on this. You know, we're looking at upright MRIs, CT scans. Of course, it's a big topic to dive into now, but if you do want to speak about it, just feel free to reach out to me and we can discuss it further. Otherwise, we've got ligaments, starting with the apical ligament. It's a very small ligament here, ultimately designed to stabilize the cranio-cervical joint by limiting really all sorts of ranges of motion right here. So you can see it's going to attach to the clivus, the base of the occiput, and attach to the top of the dens there. And unique fact about this one, they've actually found it to be absent in 20% of people. So really interesting. Okay, the alar ligament, it's going to limit cervical rotation mainly, but it's also going to limit cervical lateral flexion. It's very commonly torn in severe rotational car crashes, right? So a lot of my auto cases that I see a lot of the alar ligaments. The MRI report comes back and it's incredible. What they're doing is specifically taking that MRI of the top region of the spine, right, the craniocervical junction. Okay, moving on to the transverse ligament. This number one goal is going to be to prevent anterior movement of the atlas from the axis. So you can see here, this right here is going to have a hard time going forward. You want these to stay connected. Now, if this were to be ruptured, of course, that atlas is going to displace anteriorly. And most commonly, you will see this with hyperflexion injuries, whether it's sports injuries, car crash, whiplash, you'll see it. Okay, moving on to the cruciform ligament. Now, this one's going to have a vertical and horizontal band. Vertical here, horizontal here. It has a very similar function to the transverse ligament in that it's going to hold up the dens up against the atlas to prevent that anterior displacement. Now, the only difference here is that the vertical band is going to be attached to the occiput up here, and then the inferior band is going to attach to the body of C2, adding to that stability. Alrighty. Lateral atlanto-occipital ligament. We have, this one's going to be responsible for limiting extension of the occiput on the atlas, and then the lateral atlanto-axial ligament. Again, you've got two of these, and they're going to be responsible for limiting lateral flexion on the atlas. Okay, anterior atlanto-occipital is going to be responsible for limiting extension of the occiput on the atlas, and then the posterior, this one coming up, posterior atlanto-occipital is going to limit kind of that hyperflexion from those injuries that you'll see. But yeah, it's going to be very similar to the anterior longitudinal and the posterior longitudinal here. The only difference here is that the anterior longitudinal, it's going to be running all the way from the occiput all the way down to the sacrum, L5 there. And then same thing with the posterior, going to be limiting that flexion, starting occiput, going all the way down to the sacrum. And then the tectorial membrane, very similar to both the transverse ligament and the cruciform ligament. It's another ligament dedicated to keeping that atlas attached to the dens so that it does not anterior displace. Ligamentum flavum. This one's going to travel from the occiput all the way down to the lumbar spine, limiting flexion. Whereas the nuchal ligament's also going to limit flexion, but this one's going to stop at C7. So we've got occiput down to C7. All right, anterior atlantoaxial. This one's going to be making sure the atlas does not go up into a steep extension. Whereas the posterior atlantoaxial, again, steep flexion. Coming down to the end here, intertransverse ligament. This one's, of course, going to be limiting lateral flexion. It's going to run all the way down to L4, L5, whereas the interspinous ligament is going to be limiting flexion again. A lot of ligaments to limit flexion of the spine, but this one, again, yeah, is going to travel all the way down from the cervical spine all the way down to the lumbar spine. Now, really quick, I know this may have seemed to be like drinking from a fire hose, a lot of ligaments, but in reality, the one thing that I want you to take away from this is the number of ligaments that are here protecting the upper cervical spine and just spine overall. But just knowing upper cervically specific, we've covered 17 ligaments, 22 in total, just because some are bilateral, but hopefully you can see how the body really prioritizes this area up here, making sure it has maximum stability. That's the goal. Okay, moving on to my favorite topic, muscles. Now, there are a lot of muscles that attach to C1, C2, and even both of them. So what we will first do is that I'm going to start by describing the ones that attach to both C1 and C2. And then after that, we'll go with the muscles that are just attached to C1. And then after that, we'll go through the ones that just attach to C2. Now, there are 17 muscles in total. We add them all up. Actually, yeah, because there's a couple duplicates. 18 there. Okay, levator scapula. This one's going to attach from the superior medial border of the scapula all the way up to the transverse processes of C1, C2, C3, and C4. Now, if you look at this, you can imagine how the positioning of the head and the neck influences this muscle. Massage therapist, how often do you find that this muscle is taut and tender on your patients? One side more than the other. Now, let me encourage you to just look at the positioning of the head and the neck and look to see if it's translating to either the right or the left. Because more commonly, from what I see, is that the neck is going to be translating away from the side of the really taut levator. So just something to think about. Okay, splenius cervicis. This one's going to be running from the upper thoracic spine to the transverse processes of C1, 2, and 3. It's very common to see this muscle stretch and fire up with forward translation, right? So the levator is going to be lateral deviation. This one's going to be anterior deviation. I see a lot of this with, of course, anterior head carriage, and most commonly affected, right, by that text neck phenomenon, right? My teens, my college students that I work with. And I can guarantee you that you also see this amongst your patients as well. All right, longus colli. This is a deep muscle attaching from the anterior aspect of the atlas, and it's going to run all the way down to the upper thoracic spine. It's a very interesting muscle because some fibers are really short and some fibers are a lot longer, but ultimately is going to be responsible for neck and cervical flexion. Obliquus capitis inferior. This is the one we kind of mentioned prior. Here, you can see it's going to connect from the transverse process of C1 to the spinous process of C2. Again, this one's really, really important, so I'm going to save it for the neurology neurology modules, where I'll be diving deeper into this one along with 3 others. There's 4 total suboccipital muscles that are really, really important. Okay, and then obliquus capitis superior is going to attach from the back of the skull to C1. Rectus capitis posterior minor attached from the back of the skull to C1. Again, these two, superior and then posterior minor, I'm going to discuss in the neurology module. Rectus capitis anterior, going to be running from the occiput to the transverse process of atlas, heavily involved when the atlas is, again, stuck in that rotation. We'll see that later. Rectus capitis lateralis, attaching from the jugular notch of the skull to the transverse process of atlas. It's a very deep muscle that becomes a problem when the atlas side slips due to injury here, but not really rotational with this one. This one's going to be when it side slips, based on the biomechanics, it's going to ride up on one of the condyles, and then it's going to ride down on the other condyle. And the one that it rides down on is going to be the one that's going to stretch, and you're going to see that rectus capitis lateralis fire up and become very taut. Okay, now moving to C2 muscles, the axis. Okay, rectus capitis posterior major, attaching from the back of the skull to the spinous process of C2. Now this is the last one of the 4 in which I'm going to be saving for the neurology module. Okay, longissimus cervicis, running from transverse process to transverse process. Spinalis cervicis is the most medial of all the erector muscles, traveling from spinous process to spinous process. Semi-spinalis cervicis, there's a bunch of these muscles that run from the transverse process of the cervical vertebra to the transverse process of the upper thoracic vertebra. Okay, multifidus, rotator longus, and rotator brevis. Now, similar to the semi-spinalis cervicis, all 3 of these muscles are going to run from spinous process to transverse process. Now, keep in mind, multifidus is going to be skipping 5 levels or 5 vertebrae from the origin and the insertion, whereas the rotator longus is going to be skipping 2 vertebrae, and the rotator brevis is going to skip 1 vertebra. Now, the problem here is that when the facet joints are injured, these 3 posture muscles can be inhibited from firing. And when the brain starts using other layers of the posture muscles, let's use the quadratus lumborum, for example. But once the facet heals from whatever injury that happened, it doesn't necessarily mean that these muscles are going to be activated again. In fact, a lot of the research is saying that these muscles have been implicated in chronic neck and back problems because of the fatty infiltration that is occurring from disuse. So by having exercises, or by having someone to refer to that does have exercises to ultimately help awaken these muscles, get them re-stimulated, can really help the person recover faster. And from my personal perspective, I've seen patients hold their adjustments a lot longer as well when they're able to exercise accordingly with the right ones. Okay, wrapping things up here, we've got anterior intertransverse ligament, or ligament muscle, again, running from transverse process to transverse process on the anterior side, which is going to aid in lateral flexion of the neck. And then we also have them running on the posterior aspect of the transverse process as well. Posterior intertransverse muscle. Okay, that covers it for muscles. I look forward to seeing you on the next module.